Welcome to Telling the Tooth, the official mental dental podcast. I'm your host, Dr. Ryan Gross, and I'm joined today by my co-host, Dr. Laura J. Cox.
Good evening.
We have a great episode with Dr. Di Giosia today. He's someone I had as a professor during dental school and residency, and he's here to talk to us about the contemporary topic of sleep apnea.
I'm pleased to meet with him today, both because it's something that I get asked about regularly in my practice and academic life, and also because he has a very charming Italian accent. So he's quite calming to listen to as he discusses how he manages obstructive sleep apnea.
Absolutely. Well, with that said, I hope you all enjoy the interview. Dr. Massimiliano Di Giosia is a graduate of the School of Dentistry in Chieti, Italy. He completed a residency program in Orofacial Pain at the University of Kentucky in 2007, directed by Dr. Jeffrey Okeson, and an orthodontic residency program at the University of Cagliari, Italy in 2011. He's a diplomate of the American Board of Orofacial Pain, a certified expert dentist by the European Academy of Dental Sleep Medicine, and a fellow of the American Headache Society. Dr. Di Giosia was appointed assistant professor at UNC in June of 2015. He's responsible for clinical activities in orofacial pain, TMD, and dental sleep medicine. He focuses on clinical research as well as teaching and supervising the residents of the school's Orofacial Pain residency program. He has published several articles and book chapters in the field of orofacial and dental sleep medicine, and he's co-editor of the textbook Dental Management of Obstructive Sleep Apnea, a Practical Manual. Dr. Di Giosia, thank you so much for joining us today.
Thank you. Thanks for having me. Pleasure.
Absolutely. Well, I just wanted to start, by asking you, how did you become interested in managing sleep apnea?
Yeah, sure. It's been now a few years. It's when I did my residency in Orofacial Pain at the University of Kentucky with Dr. Jeff Okeson many years ago. It was from 2004 to 2007. One of my attending that I think a lot of dentists in the US knows, because he's very famous for one of his book on the management of dental management of medically compromised patients, is Dr. Don Falaise. He was one of my attending there, and he had a special interest in sleep apnea. So that's when I started. I didn't even know what sleep apnea was, and so we started the Orofacial Pain residency program, and part of the educational training and also clinical training was management of patient with obstructive sleep apnea with Dr. Falaise. So that's when I started, and it was a very interesting experience also because he was involved already for a long time, in a way, with the management of obstructive sleep apnea. So I had the opportunity to see a lot of long-term follow-up patients during my residency. So it was interesting. Also, he was using a lot of different appliances, so not only one, but it's been now since 2004, so probably 16, 17, 18 years, so a long time ago. Yeah.
Oh, wow. That's great. Could you explain some basics about sleep apnea and how a dental professional can contribute to the management of it?
Sure. Sleep apnea is mainly part of what we call sleep-related breathing disorders. It's mainly obstructive sleep apnea, but then you also have central sleep apnea, another couple of medical disorders. So that's why it is very important that we need to have a medical diagnosis done, ideally by a sleep specialist, but by a physician. Because we, as a dental provider, we can help a lot, actually, patient with obstructive sleep apnea. We cannot do much for some other, sleep disorders. So that's why the first step is the diagnosis. Mainly what obstructive sleep apnea is just a partial, almost a complete obstruction of the airway, of the upper airway, with a reduction of airflow equal or more than 90% from baseline, with a duration of at least 10 seconds. So these patients, what they do, that's the definition of apnea. They, in simple words, they stop breathing during the night. And But the important difference between obstructive sleep apnea and central sleep apnea is that the obstructive sleep apnea, they have the reduction in flow, but they still try to breathe. They have what we call respiratory efforts, because it's a very mechanical, anatomically based problem. So usually they have an obstruction behind the tongue and the soft palate, usually, but they are trying to breathe. So you can see their chests and their abdomen moving. And there's a way to measure that also during the sleep studies. And then what happened, they have because they don't die for asphyxia, okay? They just, at one point, they have what we call an arousal. So they have a micro arousal. So in a way, they wake up, if you look at the EEG, even though they are not aware of waking up. And so the brain wakes up, so the muscle regain tone, so they breathe again, and the cycle starts again. The difference with central sleep apnea is that they do not have the respiratory efforts. So they don't, because they don't have like a obstructive event. They have an anatomically obstructed area. So that's why with our oral appliances that mainly move the jaw forward and open the airway, we cannot manage patients with central sleep apnea. So that's why, again, very, very important, the diagnosis. And to go back again, the definition, if you want, of obstructive sleep apnea, the way there are several different level of severity of obstructive sleep apnea. We have mild, moderate, and severe. And there is one number, sometimes in a way probably a little bit abused number. It's called the AHI, is the apnea-hypopnea index. And based on this number, the physician gives the severity of the apnea. So apnea, again, apnea-hypopnea index means the number of apnea plus the number of hypopneas. So again, hypopnea is a different definition than apnea. It's kind of a smaller apnea, if you want, even though it's not. The real definition is that they have to have at least 30% drop in airflow from baseline that lasts again for 10 seconds. You remember the apnea was more than 90% drop of airflow, but hypopnea is more than 30%. They last for at least 10 seconds, and they have to have an oxygen desaturation of at least 3% or an arousal. So those are all technical terms that, again, if we deal with sleep apnea, we should know. But that's where it's mainly medical term and medical definition. And based on this definition, the physician during the sleep study can make a diagnosis. So you got the number of apnea, the number of hypopnea divided by the hours of sleep. That's what you get. You get this little number. It's called the AHI. It means, like, let's say if a patient has 30 apnea and 40 hypopnea, so it's 70, slept for 7 hours, so 70 times 10 times 7, it's 10. So the patient is an AHI of 10, and 10, it's a mild sleep apnea, because from 0 to 5, it's normal. From 5 to 14, it's mild. 15 to 29, it's moderate. More than 30, it's severe. And that's where. And then also based on the severity of the apnea, there are indications, of course, for treatment, different treatment, because oral appliances is not the only one, of course. And we can talk a little bit about the different treatment that we can have.
In that example that you just gave, 70, apneas or hypopneas during that sleeping time, it sounds like a lot to me. I assume that patient's not waking up 70 times during the night. How many would you say on average would that patient be experiencing an arousal significant enough for them to be woken from sleep?
Correct. I mean, 70, well, the example I gave you was 30 plus 40, 70. Those are the obstructive event divided by the times of sleep. So at the end, the AHI is 10. But the arousal, the way is defined arousal, again, the arousal, the physician can see the arousal on the sleep study, mainly on the EEG. So it doesn't mean the patient is waking up. Actually, in the real life practice, if you ask a patient with sleep apnea, do you sleep? Oh, okay, how is your sleep? The patient said, well, I sleep all night, but then when I wake up, I'm very tired. Because in a way, they are not aware of all these events, and most of the time, it's the partner, actually, the one who's more involved with treatment with this patient, because with a lot of these patients with obstructive sleep apnea, they are very loud snorers. So the thing that usually the partner is, oh my God, they say, you snore a lot, and then of course they also witnessing apneas, and then you stop breathing, and then you start breathing again. So usually it's the partner, pushing the patient to do something, especially for snoring. But a lot of patients of sleep apnea, you will see if you look at their hypnogram is like a summary of one night of sleep study. It's very different from a normal sleep study for a normal patient, of course, but they are not aware of waking up, because again, the arousal, it doesn't mean it's not a conscious level. So the patient usually is not aware of it. Sometimes they do say that they wake up with a shocking sensation, or like they have this sensation of they're not able to breathe. But most of the time, a lot of patients say, no, I sleep all night, but then when I wake up, I'm very tired. That's the thing, and usually if they have one of the symptoms associated with obstructive sleep apnea is excessive daytime sleepiness. Usually if they have that, they do seek treatment themselves, but about 40 to 50% of patients with sleep apnea, they do not have excessive daytime sleepiness. So if that's the case, usually for them, everything is, they don't feel this sleepiness, so they don't look for treatment. It's merely the partner pushing them. And the severity varies a lot. Again, those are the definition I told you before, but we have patients that can have also 70, 80, event per hours of sleep. So those are very, very severe cases. And usually for these cases, oral appliances are not first line of treatment. There are other treatment modalities that they should go first before going to the oral appliance therapy.
And how do you typically interface with the sleep specialist neurologist that you had mentioned before?
Yeah. What we do in the clinic here at UNC is 99% of our patients, they are referred to us by sleep physicians. Because the first step, again, like every thing in medicine, should be the diagnosis, right? So diagnosis is not something that we can do. We cannot diagnose patients with obstructive sleep apnea as a dentist. We can definitely maybe screen in our office, and then maybe, because we can use validated questionnaires, and then if we are suspicious that this patient could have, based on the question, the symptoms, could have sleep apnea, we have to refer the patient to a sleep doctor. It can be also it can be also a primary care physician. Usually I do refer to a sleep physician for an evaluation and then a sleep study. So in a clinic like ours, that it's kind of already been organized like that for a few years, we get the referral from the physician already with a request for evaluation and management. And we do a first evaluation. We take a look, if the patient is a good candidate, for oral appliances, looking at their teeth and jaw and, TMJ, muscles. So, and then if they are a good candidate, we can proceed with impression and bite registrations. And then after we deliver the appliance, we go from the initial position, because we usually start at 60, 70% of the range of motion that the patient has, between protrusion and retrusion. But it doesn't mean it's going to be enough to manage the obstructive events. So after delivery, we have a period called titration of the appliance, and usually it's based with the feedback with the patient or using some objective measurements. And then once we think we are at the right spot, the patient says, I sleep much better now, I feel much more refreshed, and I don't feel sleepy during the day, snoring is gone, or it's much, much better. At that point, the subjective report of the patient, it's much better. Maybe if we use some objective measurements with some of the tools that are available now, monitoring these events and desaturation, we send them back to the sleep physician for ideally another sleep study with the appliance in their mouth. Now, the sleep study, when I say sleep study, we should say that we should define that there are different levels of sleep studies. We have full PSG, full polysomnogram, or level 1. That's one sleep study that the patient does in the lab, in the sleep lab. Usually it's in the hospital, and he has a lot of cables. He has EEG, EKG, eye movements, EMGs, of course, saturation, cannula for respiration, and the belt for the respiratory movement of the thorax and the abdomen. So a lot of data. And it is the type 1, it is also attended, meaning that the patient is sleeping in the lab and there is a tech, there's a sleep tech on the other side of the room of the lab who is checking. And also it's recorded video and audio, okay? So as you can understand, it's not probably the best place to sleep, because you feel well disabled and observed, but as of today, it's still kind of the gold standard if you want, because you get a lot of data. And then you have the type 2 PSG, same data, same all these cables and all the information we can have, but it's not attended. So it can also be done at the patient house. And then you got the type 3, what is called the, it's not polysomnogram, because, remember when you have EEG, that's when you can see the sleep. If you don't have the EEG, you don't see the sleep. I mean, you don't know if the patient is asleep or not, okay? So the type 3, it's also cardiorespiratory monitoring. It's also, it's a polygraphy. It doesn't have the sleep part, but usually it's good for measuring the obstructive events, the respiratory. In fact, it's also called cardiorespiratory monitoring. And it can be done also for diagnosis and also for titration or to check if the efficacy of the appliance. And then you have the type 4. The type 4 are the single channel or 2 channels. Usually it's the cannula for respiration and the saturation, the oxygen saturation. So there are different levels. Usually it's the physician who will decide if he needs a very well, a full sleep study of a home sleep test will be enough. But then usually I leave to them the decision of what to do. But once we send them back with the appliance in their mouth, they have a sleep study with appliance. And let's say everything is good, it's working well. We see the patient after that once or twice a year. And if they still have apnea, we still have to continue with the titration or the advancing of the appliance. So it is I think it's a very interesting field of dentistry, new, even though it's not new. Now it's very popular. It was not popular when I started doing it, but it requires a little bit of a different mindset, a lot of collaboration. So you cannot do it by yourself, or if you do it, I don't think you do a good service to the patient. So it requires a lot of collaboration, mainly with the other healthcare provider, the sleep physician. Then again, it can be a neurologist, it can be a pneumologist, with the ENTs. Because that's another aspect also, it's very important, nasal respiration. If they cannot breathe well with their nose, the appliances, usually they don't work as good as if they can breathe very well with their nose. So it requires a lot of teamwork. But it can be very, I think, a patient after they, especially if they have a lot of symptoms, excessive daytime sleepiness, feeling not refreshed when they wake up, and start using the appliance, there's such a big difference. And they say, oh, it changed my life. So I think it's a very rewarding field of dentistry too, but definitely it's a teamwork. It's not like a solo, even though, you can cut corners, you can do something in a way it should not be done. But if you want to do it the right way, definitely collaboration is the key. Especially also if you want to see patients, because the patient, they come from them. They come from the sleep physician, So that's why when you start this in your community, it's very important that you build a network. So at the beginning, it's a lot of meeting and talking and trying to get the referrals from the physicians.
Great, thanks. I was going to ask for someone, and you kind of alluded to this already, but for someone like me, who's a very light sleeper, and if I were put in that scenario in that lab room, I'm sure I wouldn't probably sleep very well. So you think that type 2, home self-test would be sufficient to get, for someone like me, I guess that's maybe what they would go with.
Yeah, usually, it depends. Usually that's the, and then every patient is different, of course, but if the pre-test probability that the patient has obstructive sleep apnea is very high, you don't need a very sophisticated test in a way, okay? So if you have a patient that, it's almost clear that all the questionnaires are, all the way, the numbers are all the way up, and a lot of symptoms, and maybe also the comorbidities associated with sleep apnea. So you already know the physician, this guy has a very high probability of having sleep apnea. Usually they don't need a very sophisticated test, so they can use the home sleep test. But you are right, because a lot of patients, even if they go and sleep in the lab, they say, well, I really don't know how much reliable is that thing. I didn't sleep much. I slept probably 4 or 5 hours, because that's not my, it is very difficult. And then you have some patient with, because, you can have sleep apnea, But it doesn't mean you can have more diagnosis. You can have sleep apnea and insomnia. They're actually very comorbid. Plus, some people, they have changes in the circadian rhythm. Like if you have a night owl, these people, they go to bed at 2 a.m. and then they wake up like, they can wake up like 10, 11 a.m. So usually when they call you for a sleep study in the lab, I mean, you have to be there around 7 p.m. or something like that. If you have a patient that goes to sleep at 2 a.m., he's not going to fall asleep at 7 p.m. in the lab. So that's another problem. So there are several situations or conditions that you have, the physician has to evaluate, but usually what guides them is the probability of the pre-test probability of having sleep apnea. But you're right, Ryan, a lot of patients, they complain about that. I say, yes, I slept there, but I didn't sleep much. And in the ideal world, they should have at least 2 studies. And actually in research, with people with funding and grants, they do that. It's called the first night effect. So you do not consider the first night because you need like an accommodation for that new situation. But in real life, for clinical, no way. I mean, just one night, that's what happened. But definitely it can be a problem. You're right. In that case, of course, if you can do something in your bed, it will be probably better because it's a familiar environment for you.
You mentioned the comorbidity of insomnia with sleep disordered breathing. I wanted to ask, what about for patients where you rule out sleep disordered breathing as an etiology, but the patient still has or struggles with insomnia, difficulty falling or staying asleep? How do you triage or manage those patients?
Yeah. Again, insomnia is actually probably one of the most prevalent sleep disorders in our society. And insomnia is mainly either difficulty in falling asleep or staying asleep. Okay. It is comorbid with sleep apnea, but you can have just insomnia. And sometimes actually you have patients with obstructive sleep apnea and insomnia, and you manage the sleep apnea, but they still have the insomnia. So, and usually we do, there are questionnaires also that used in clinic for screening, but definitely if it's just insomnia without the sleep apnea, the management usually for insomnia, again, it's medical. Actually, the one that works probably better, there's a lot of evidence now, is CBT. It's cognitive behavioral therapy for insomnia, more than pills. Even though the patient usually, most of the time they want a pill so they can fix it. But a lot of sleep physicians, sleep specialists, they always go first with CBTI, cognitive behavioral therapy for insomnia. That requires a lot, of course, collaboration from the patient. It's not just a little pill that you take and you go to sleep. But it is effective, and actually, if you read the guidelines, it's probably the first recommendation. And then there are other, of course, sedatives. There are the old benzos, the new non-benzo hypnotics, a lot of medication, the sleep hygiene. Of course, with insomnia, also the physician has to check the comorbidity with anxiety. Several things. Sleep medicine, it's a very interesting field, and that's why also we as a dentist should be aware that it's not only sleep apnea, because sometimes if you take a 2-day course at holiday in university and you feel like it's only sleep apnea, but it's not. So there are a lot of other comorbidities that could go together. So that's why, again, collaboration with a physician, it's very important, because he has to, the diagnosis to come from them, from the physicians.
Great, thank you.
How do you decide which treatment you're going to pursue, since CPAP and the maxillomandibular advancement surgery are both shown to be effective? How do you decide which patients get oral appliances, and when do you go with oral appliances rather than these other approaches?
Sure. Now, if you look at the guidelines from the American Academy of Sleep Medicine, so the medical society, in case of patient with mild or moderate sleep apnea, so if we think again back to the little number, the AHI, so from an AHI from 5 to 29, 30, because again, 5 to 15 is mild, or 15 to 30 is moderate, oral appliances are actually indicated as a first-line treatment. In theory, the physician could give the patient the option, what do you want to do? Do you want to do oral appliances, or do you want to do a CPAP? Okay. Now, if it's severe, more than 30, they have to go with CPAP first. Okay. And then if they are not tolerant to CPAP, and a lot of our patients are actually CPAP intolerant patients, we can consider other treatment, either neural appliances or something else. One thing also we have to consider that it doesn't mean a patient, we can have two patients with the same AHI, okay? Let's say two patients with mild sleep apnea, an AHI of 14, okay? But they could be very different if you look only the AHI. Because, if you have a patient who has an AHI of 14, it's relatively young, it doesn't have a lot of comorbidities, he didn't have any stroke, or it doesn't have any arrhythmia. And then the other patient with the same AHI, but he has an arrhythmia, he already had some, it's hypertension, it's resistant to medication. That patient, it's probably a little bit more severe than the other one. So that's why also the treatment decision is usually decided together with, it's usually decided by the physician. In our case at UNC, because we have such a strong collaboration, we do have some, of course, some interaction with them when we discuss some cases. What do you think about this patient? I would say by guidelines, oral appliances are for mild and moderate sleep apnea. First line treatment is CPAP. For severe sleep apnea, CPAP first, and then if they are intolerant, oral appliance. There are also, as you said, you mentioned the mandibular MMA, the orthodontic surgery mainly. There are other options, surgical option for a patient with obstructive sleep apnea. You have the oral surgery, procedure. It's a very actually, there are several studies showing that it does work in the selected patient. I think at this point, you have to consider also the age of the patient, the comorbidities. I mean, is the patient a good candidate for that? Also from an orthodontic, point of view, if you want. What about the structure of the patient, the profile of the patient? But definitely if it's a young patient and with a severe sleep apnea, and it could be considered. Because remember, both oral appliances and CPAP, they do not cure CPAP. It's not like it's a fix, okay? They don't cure sleep apnea, they manage sleep apnea. So it's not like you use the oral appliance or the CPAP for 6 months and then you are cured. No, if you don't, you have to use it probably for a lifetime, okay? So that's why also another thing to consider together, definitely it's a physician decision, it's weight loss, for example. If a patient is overweight or very obese, weight loss could be very helpful. In some cases, bariatric surgery also gets involved for the management of some of this patient. We have all the surgical procedure of the soft tissues. Those are all ENT's surgical procedures. They used to do this UPPP, uvulo-palatopharyngoplasty. Mainly they make the soft palate shorter, and as a single procedure now, they don't do it very frequently. It's a single procedure they combine with other procedures, because one thing we have to keep in mind also is that usually the obstruction in this patient is not, well, I would say never, but usually it's not just one side, okay? Let's say you have a patient with an obstruction behind the soft palate and behind the tongue, okay? The ENT takes care of the obstruction behind the soft palate. So maybe the patient actually doesn't snore anymore, because snoring is vibration of soft tissue, but he still has the obstruction behind the tongue. So the patient maybe say, oh, I'm fixed now, I don't snore anymore, but they still have the apnea. So all the surgical procedures, they have to be, hopefully in the near future will be some, what we call personalized medicine, precision medicine. Right now we go a lot with guidelines and with severity of apneas. At that point, if they don't respond to the less aggressive procedure like CPAP and oral appliances, other procedure more aggressive can be definitely considered. And we do, talking about the MMA, we have patients that do very well with oral appliances, but then they say, doctor, I don't want to use this for all my life. I understand, especially young patients, that's something that could be considered, especially if it's a patient with a, class 2 mandibular retrognathia, a lot of patients are. Definitely a consultation with an oral surgeon could be done, and consider maybe if the surgery is a good treatment for this patient. Again, multidisciplinary approach for the management.
Thank you. But with mentioning class 2 patients, what fraction of patients are kind of class 2, class 3, open bite, deep bite? Like, are there particular malocclusions that are tied to OSA phenotypes?
Yeah, there are risk factors, and craniofacial anatomy is one of them. And usually it's, again, the class 2 patients with, bigger overjays. And that's definitely, and also with narrow palate. And that's why then we have all this thing behind the kids and the expansion, but definitely those are risk factors. Because, if you think about, remember, the obstruction is usually behind the soft tissue, the soft palate and the tongue, okay? So if you have a very crowded airway and upper airway, so you got, they can be crowded for two reasons. They can be crowded for soft tissue. They are, bigger, or maybe because the skeletal structure of the patient is not well developed. So those are all risk factors. Of course, we have to consider also the tonsils. We have to consider, again, also the fat deposition, especially in men, because also when we have, there are actually interesting publication of patients with same BMI. If you consider a patient with same BMI and then they've done MRIs of the tongue and the face, they've seen that two patients with the same BMI, one is apnea, one not. One with apnea has a lot of much more fat deposition in the posterior part of the tongue, in the base of the tongue. So there are several things, but definitely the craniofacial anatomy of narrow palate and short mandible, it is a risk factor. And other risk factor, of course, are, as I said, obesity, age. It kind of gets worse with age in a way, and of course using sedatives, it's another risk factor. But I would say that the biggest two risk factor is the craniofacial anatomy and the weight. We see just few class 3, not many. In our clinic, if I just thinking, I would say we have a lot of class 2. That's another thing that also relates a little bit with one of the side effects of sleep, the oral appliances. Maybe you can talk later.
I was just going to ask about that
Yeah.
in terms of, especially when you're saying those, CPAP and those oral appliances aren't curing sleep apnea, they're managing it. So you have to use them for a long period of time. And I assume as you're repositioning and maintaining that mandible and tongue anteriorly for a long period of time, it's probably going to lead to some occlusal changes.
Yes. Yeah. Side effects of oral appliance therapy usually are, we have two kind of side effects, two types, okay, short-term and long-term, or reversible or permanent. The short-term are very common, but usually they get used to it, or we can manage them very well, like hypersalivation or dry mouth. Depends also from the lips, if they can have a lip seal or not. Some tooth discomfort, some, jaw pain, muscle pain, usually muscle pain more than jaw pain, but usually you get used to them and you give them some advice, some management, and they get used to it, okay? I would say the vast majority, they get used to it. The only side effect that can be permanent, it's the dental movement. So dental malocclusion, dental changes. What happens with this, if you think, especially for the orthodontist, what we use mainly are mandibular repositioning devices. So they move the jaw forward. Those are and one of the most used actually is the herbs. So the herbs, been used in the orthodontic profession for a long time. So what you have as a side effects, that when you use the herbs for orthodontic treatment, it's actually a good one, because you're looking for dental alveolar compensation for a class 2 patient usually. Hair growing in the mandible, but that's another thing. I don't know if you can do that or not. But what happened, mainly the side effects, you have a retroclination of the upper teeth, upper incisors, proclination of the lower incisors. And then at that point, it depends where you start. Because if you start with a patient who has like a 5mm overjet, even if you have this kind of side effects, you're okay with that, right? Actually, those are positive if you want to, positive side effects if you want. But if you start from a very, normal or even shorter overjet, like a 1mm or even an edge to edge, you can, have an anterior crossbite, because that's what happened mainly. As a reaction forces on the teeth, that's what they do. They move the upper teeth backward and the lower teeth forward. Now, of course, this is it's not like an overnight change. It takes time. So we have try to use some tricks, try to avoid them, or, try to delay the onset of those dental changes. But if you look at the literature in the long term, patients using the appliance for 7, 8, 10, 15 years, the vast majority of patients, they do have some of these dental changes. Again, sometimes just a 0.2, 0.3, 0.4mm. So it depends where you start. Some of them, they have no changes at all. I have follow-up at 10, 12 years of continuing using the appliances, no changes at all. Other patients, though, if you look at the big numbers in the literature, Probably, if I remember, a study of the group in Vancouver, the group was more data in the long term, Alan Lowe and Fernando Almeida and then Ben Pliska. If I remember well, a study, average use of the appliance for 7.5 years. I think only 10 or 15% did not have any dental changes. So 85, 90% they did have changes. And then you can actually divide those changes in negative or positive if you want. It depends usually most of the time from how much room you have for, compensation of this movement. Again, the overjet usually, but you do have it. And those are again, long-term and slow process. One thing that they notice usually since the beginning is that when they wake up in the morning, they feel like, oh, my back teeth don't touch, because they have a posterior open bite, and sometimes you cannot see it. But if you ask them to bite on a shim stock, they cannot hold it. That's mainly a muscle brace position, because you think about this, slept all night with the jaw forward. So the first opening in the morning, they touch mainly on the incisors. But then we teach them exercises. We give them like a little aligners, so they bite on it. So those are aligners we use. We mainly, before giving them the appliance, we do a bite registration on their normal maximal intercuspation. So what they have this little aligner, so they bite on it in the morning. So it's, pushing the jaw backward. So we do have some tricks and something we try. We ask them, some of them we use, Essex retainer, during the day, but definitely if you look at the literature, you cannot avoid those changes. And again, sometimes it's very small. Sometimes you have a lot of room, so they are not, they are okay. But also, keep in mind, Ryan, that we are treating a dangerous disease in a way, especially if it's moderate to severe sleep apnea, because he can have a very negative side repercussion on the patient health. It puts a lot of strain on the cardiovascular system, mainly, also the nervous system, central nervous system. So we always have to weigh the pro and the con, and think about what we are treating. But of course, we always tell the patient at the beginning is we give them all the indication, all the information. They have to sign a consent form, and where it's very clear that these occlusal changes can happen. And sometimes, just few cases, they do refuse treatment. Especially young patient worried mainly about the aesthetic. I kind of understand that, but if that's the case, and if he was referred by a sleep physician, what I do, I send a letter back to the physician telling him, listen, the patient refused treatment, please get in touch with him again for some alternative treatment. Because again, especially if they have moderate to severe apnea, it has to be managed. So it can be a dangerous thing. So yeah, but definitely it's a very common side effects. And it happens almost with all the appliances. There are no difference between one appliance. Now, there are sometimes you see some very short, small data with few case report, or our appliances doesn't move teeth. If you look at the publication, they all do it. And in the long term, there's something that doesn't have to scare the patient or the provider. It's very slow. You can catch them at one point, you can stop and reverse. But once they happen, sometimes they don't go back. Of course, you need the orthodontist to take care of it, management.
Do you ever manage it in partnership with an orthodontist so you can both correct a severe class 2 and the OSA?
Sometimes with the thing about this sleep apnea appliances is that the way they work is mainly with protrusion. So we need something that's pulling, of course, the jaw forward and keeping the jaw there during the night. Okay. So I think at one point, it's definitely the collaboration with the orthodontist and the oral surgeon. That's definitely something, as we said, to consider. Because again, the oral surgery and what it does, it's mainly it's a permanent way to put the jaw forward. If you compare to the oral appliances, it's just a temporary repositioning of the jaw forward. But definitely, the collaboration is the key. So it can be very important, also case by case, and consider that. Then we have all the other big field of the pediatric sleep apnea. That's another thing, because now it's all the expansion and the functional therapy for class 2, it's pushed a lot. I would say mainly more by general dentists with an interest in sleep. But even if you look at that carefully at the data that we have, yes, we have some encouraging data, but it's not like black and white, like a lot of things in medicine, right? It's a lot of gray areas. So yes, they can be helpful in kids. The treatment can be different, even though for pediatric sleep apnea, the first line treatment in case they have it's tonsillectomy and adenoidectomy in case they need it. But definitely the role of dentistry and orthodontics in the especially in the pediatric patient, definitely it's big. And hopefully we're going to have more data with more clinical indication, clear indication when, who's going to respond and when to do it or when not to do it.
Great. Let's get a little controversial for a second. I want to ask you, what are your thoughts on maxillary expansion, palatal expansion, and its potential effects on sleep apnea and quote unquote curing it?
Yeah. Again, as I said, if you look at the orthodontic literature in pediatric sleep apnea patients, there are data. Actually, several studies has been done by a colleague of mine from Italy, Dr. Pirelli, who's done few publications with the group of the Stanford group, GME and with kids with palate expansion, and you follow them. She has a follow-up, I think, small numbers. We're still talking about small numbers, probably 12 years with some, promising data. But then if you keep digging, you also see that there are cases with actually palate expansion, and they call it mandible expansion. It's not really mandible expansion. It's just, dental alveolar kind of compensation of the lower teeth. It's interesting that some cases actually get worse after that procedure. That's also another study from the group on Stanford. If I remember, it's Dr. Stacy Kuo at Stanford. So I think there are some data there that, promising, especially in the pediatric. We still need some, what we know, what it works mainly for, especially for adults, is the mandibular protrusion. That's what we need, okay? Now, there's all this big aspect now of doing maxillary expansion also in adults patient. And actually, I don't know if we should call it maxillary expansion of dental alveolar kind of development, because, with some strange device and saying this, the forces are very low forces, they can grow bone. So you have this expansion of the airway without doing the surgical procedure in adults to open the suture. But that gets very kind of gray area, not much evidence, a lot of very controversial, statement mainly by the company pushing these devices. So I will probably not recommend it as a first-line treatment. If you have a patient say, I have this palate, I really don't like it, my smile, it's fast, so I want to have some orthodontic treatment done. My recommendation is just do it for ortho reason. And then if the sleep apnea gets better, we're all happy, but that sleep apnea, meantime, should be managed with something else, okay? Especially if it's mild. I mean, if it's moderate or severe, we cannot promise a patient that you will have a beautiful smile and apnea will be gone, even though there are companies saying that around, but that's not the way. And again, especially if it's moderate severe, adult patient with hypertension and arrhythmia, cardiovascular disorders, we should not take it this lightly. I mean, the disease can be very dangerous.
To continue in the vein of controversial topics, what role do you feel that premolar extraction plays in sleep apnea?
Yes, that's another. Yeah, I think we are again. If you look at the data and the idea behind that is the same. Like if you do premolar extraction and then you want to retrude all the anterior group back, it's like if you do that, the upper airway are going to be smaller. Mainly, what is going to be smaller, it's mainly the space for the tongue, because the tongue, it's a big player in this, okay? So especially when we sleep, all the muscle relax and the tongue can kind of fall backward, can contribute to the obstruction. So as you know, probably sometimes something, it makes sense. I mean, it's logical, but it doesn't mean it's true, right? So you should look at the data. And then, like a lot of things, if you look at the literature, you can kind of build a presentation the way you want, because you have data saying, yeah, there are some, the airway gets smaller. Other data say, no, there's no correlation. So definitely, we really don't know 100%. Well, it's very, very unclear, because if you look at especially some recent systematic review, one that said yes, there is some correlation. The other said no, there is no correlation. There was a study actually came from UNC a few years ago, but without the sleep study. Because also you have to look at the studies, how did they look at the airway? How did they look at the apnea? Did they do like a 2D cephalometry? Did they do a 3D CBCT? Did they do a sleep study or just questionnaires? So I would say that, especially for the orthodontists, do the extraction if it's needed for your ortho treatment. But as of today, we cannot say, no, don't do it. They're going to get sleep apnea. Because also, when you do this, usually in kids, how can you predict what's going to happen in 5, 10, 15 years? What about if the kids stay slim and it doesn't have any other risk factor? What about if the kid gains 100, 200 pounds, with the obesity and there are too many factors. Because remember also something I didn't mention before, but it's very important. One of the common denominator for this patient is some airway restriction, anatomical. They have, in a way, smaller airways. Now, remember, they do not have sleep apnea when they are awake, Sleep apnea is called obstructive sleep apnea because it's mainly when we sleep, Because let's say you have a smaller airway, both for, it can be just because of short mandible, a small palate, or it can be for soft tissue, bigger tongue, or fat deposition, overweight, or combination of both, So when we are awake, we don't have these events. Now, when we go to sleep and we lose this neuromuscular compensation, because, remember, all the muscle, they lose tone, And if you remember the anatomy, the pharynx has no bony support. It's like it's a muscle thing, So if the muscle tone, they lose, if the respiratory muscle, the upper airway, respiratory muscle, they lose tone, you have a collapse, So this anatomical thing, it's a denominator for a lot of these patients, but there are also some non-anatomical reason for obstructive sleep apnea, like poor upper airway muscle function, some low respiratory arousal, and eye loop gain. The loop gain is the ventilatory response mainly, that you can have two patients with the same anatomy. One is going to have apnea, one not. So yes, anatomy, it's a big one, but it's not only that. And actually now there is a group from Australia, Dr. Eckert, he was in Boston first. He's trying to phenotyping this patient, or endotyping if you want, and actually trying to do that with a regular sleep study. So we could see, this patient, maybe it's more important for him to have, it doesn't need an anatomical oriented treatment. Maybe he needs something for his loop gain, and usually, it's a medication now. So, the more you start digging, the more complicated it gets, but hopefully it also is going to get more personalized. Because also there is a company now, a pharma company, they are in a good, I think they're already in clinical trial with some good promising results. They're using a medication. So they use medication to treat obstructive sleep apnea. So if you think about a few years ago, say, how can you do that? It's an anatomical thing. Yes, it is, but it's not only that. So those medications, actually it's old medication. They're trying to mix two molecules, and they've seen that what they do mainly, they increase the tone of the muscle. So the muscle, when you go sleep, they don't lose tone. So the upper airway, they remain open. So there are several things to consider, and hopefully sooner than later will be not like now, like a one-size-fits-all treatment kind of. But it's not only anatomy. In some cases, you need medication, hypoglossal nerve stimulation, and sometimes oxygen for the loop gain. So that's why, again, collaboration with the physician is the key.
Thank you so much. This has been a really fun and informative conversation. I just wanted to open it up in case you had any final thoughts or anything else you wanted to share with us that we haven't covered yet.
No, I think probably one suggestion, but it's nothing new. If someone is interested in this, field of dentistry, get involved, get more, of course, education with hopefully with some more scientifically based, organization. There are a lot of commercial interest behind that, like everything in dentistry, but get more involved, get more training in the field, because it can be very, very rewarding. And also, from a financial point of view, because, especially, we all have to look also, we have to run our practice. It can work very well. And there are several colleagues here in the US that they are limiting their own practice just to the management of sleep disorder, mainly obstructive sleep apnea snoring, and they do very well. Of course, the key of that all the practice that I know that are doing well is the referral network. So they've worked a lot with the referral providers in their community. So it takes some work at the beginning, like, everything, but it can be very, very rewarding.
How do most people get interested in this field? Is this something that people learn about in a class in dental school, or something that they take a continuing ed course and then that inspires them to pursue it further?
Yeah. Usually until a few years ago, I think it was mainly by, some CE courses or something you heard about it, or a friend of yours. So, oh, I got these appliances, I had this snoring, mainly for snoring, is managing my snoring. And it's still, for the vast majority, I think, of the dental schools is still the same. And there are some dental schools now, they start they included some pre-doc and post-doc kind of training in the field. If you look at UNC, for example, the dental students, they do get just some, probably 3 or 4 hours, pre-doc. But now we also have we have an elective in dental sleep medicine. Actually, next week will be the last session of a semester-long elective class on dental sleep medicine. And we had a lot of interest actually from the 3rd and 4th year dental students. We met once a week since August, doing mainly, of course, presentation and seminars, but also they have a clinical rotation in the clinic here at UNC, the dental sleep clinic, and they've been very interested. And also probably a month ago, a few D1 students, they just sent me a message saying that they were interested in funding the first dental sleep medicine club. So now there are probably 25 of them, and we have this dental sleep medicine club, at UNC, and we met once, and definitely there is an interest from them just to learn about this field. And everything started from one single student who had a personal experience with his father being managed with oral appliances for sleep apnea. So I would say still a lot of CE courses, a lot of them done also by companies, labs. And we have a couple of, probably one organization in the US, that's the American Academy of Dental Sleep Medicine. It's probably the oldest organization for dentistry, it's organized dentistry. They do have, I think, a lot of, the annual meeting, they're usually very interesting. They also have a certification process. The membership for dental students is completely free, like also the meetings attendance also free. So there are resources now, definitely more than when I started. I would say probably still for personal interest, or because I don't think a lot of school has, I don't think a lot of dental school have some curriculum on dental medicine. Maybe, physician, they get 1 or 2 hours in medical school. So actually probably we get more as a dentist in a dental school, because it's still kind of a new field, if you want, even though it's been around for a long time.
Okay, very good. Well, thank you again for taking time out of your evening to be with us today and share all of your wisdom and knowledge on this topic. It's been really informative for me and Dr. Jaycox. So hopefully our audience,
thank you.
I know they'll find it interesting as well. So thank you again.
Thank you, Ryan. Thank you.
Yeah, of course.
Thank you very much.
Well, that was great. It was nice to talk to Dr. Di Giosia. I've always run into him in the hallways of UNC, but it was nice to sit down and chat with him for some time and get to pick his brain about sleep apnea. What was your favorite pearl from our discussion, Laura?
I liked how evidence-based he was, that, he was willing to bring up the importance of having a neurologist who's a sleep specialist be the source of the diagnosis, rather than it being a questionnaire or just a vague history of being exhausted, for example. And I think that's important for the field to be aware of the proper channels through which patients can be referred to dentists for management of OSA, and the proper place that we can serve in a team managing sleep apnea, rather than putting appliances in everyone's mouth. It's a relationship that we're building with sleep specialists, where we can provide these specialized appliances for the appropriate patient with the appropriate level of sleep apnea.
Definitely. And along with that, I think there are a lot of fads out there about which appliances you can use to cure people's sleep apnea by expanding palates or by growing bone. And there are always going to be fads like that. We see that a lot in orthodontics. We see that in general dentistry as well, about things that are just popular and are promoted a lot and gather a lot of attention on social media or things like that. And as you said, it's really important to stay rooted in evidence, especially when we have it at our disposal. And it may not be as appealing as some of these fads, but if we know that something works or doesn't work, that's what we have to focus on more so than just the next big popular thing that's getting a lot of money pumped into it. So it was really refreshing to hear his perspective, rooted in decades of working with patients and studying the literature. And so hopefully our audience was able to get something out of that. And like you said, this is a serious condition that affects a lot of people. I think it's something like 70 million people in America who struggle with some sleep disorder. It's more like 18 to 20 million who have sleep apnea, obstructive sleep apnea. So it's a significant portion of patients who are living with this condition. And as Dr. Di Giosia mentioned, a lot of cardiovascular comorbidities like arrhythmias and stroke and heart attack and things that can result from taxing the heart with a sleep that's impacted by obstructed breathing. So we have to take it seriously. And as dentists, we have to know our place in referring these patients to the proper channels and getting proper diagnoses, and then stepping in with treatment that's not just the big thing on social media, but doing what we can to actually help them and meet them where they're at.
Absolutely.
All right. So if anyone has any follow-up questions after this episode, as always, feel free to send us an email at officialmentaldental@gmail.com, or you can reach out to us via our social media platforms on Facebook and Instagram. But that's it for this one, everyone. Take care, be safe, and we'll see you all in the next episode.